As most of you probably do know, the National Health Council is a unique organization in that we bring together all segments of the healthcare community. We provide a united voice for more than 133 million people with chronic diseases and disabilities and their family caregivers. Our core membership is approximately 50 of the nation's leading patient advocacy organizations, and they control the governance of the council. Other members, however, include nonprofit organizations with an interest in health, professional and membership associations, biotech, medical device, health insurance, and pharmaceutical companies, as well as some organizations that are in a different category, that's sort of catch-all, but bring together everyone from the health community in all of our work. And while we're governed by the patient advocacy organizations, every member organization or company of the council has a meaningful role in our decision-making processes. The National Health Council was intensely involved in the development of the Affordable Care Act. Our efforts were guided by our 5 principles for putting patients first, cover everyone, curb costs responsibly, abolish exclusions for pre-existing conditions, eliminate lifetime caps on coverage, and ensure access to long-term and end-of-life care. All of the patient advocacy organizations that belong to the National Health Council support these goals, and they do it because of patients like Michelle. Michelle has a daughter with cerebral palsy and epilepsy. She stayed 14 years in the job that she described as miserable because she was afraid her daughter's pre-existing condition might not be covered under a new employer's health plan. Under the Affordable Care Act, children with pre-existing conditions, as you know, do have access to health insurance. We're proud to say that all 5 of the principles of the National Health Council are addressed in the healthcare reform law, and much of the council's proposed legislative language was included in the law. We worked closely with members of Congress from both sides of the aisle to ensure that the concerns and the interests of patients and family caregivers were addressed in the Affordable Care Act. Ever since the law was enacted, the National Health Council has been a leader in 3 priority areas: helping to craft the federal definition of essential benefits that health insurers will be required to offer, working with the Patient-Centered Outcomes Research Institute, or PCORI, to advance comparative effectiveness research, and helping to develop, test, and implement new healthcare delivery models that are designed to provide care in a more effective and more efficient manner. Because these initiatives and other elements of the law, because of these, the Affordable Care Act will have, and actually, as you know, already does have, significant and positive benefits for many people, including the 133 million people with chronic diseases and disabilities. Consequently, the National Health Council is very pleased with the Supreme Court's decision to uphold the law. We believe the law, though not perfect and certain to evolve over time, is already improving the lives of people with chronic conditions. But the work is not over. We think it's time to put the acrimonious debate behind us and continue working through the implementation process in a productive way so that we have a healthcare delivery system that truly meets the needs of all people, especially those individuals with 1 or more chronic conditions. The Council remains dedicated to ensuring that patients with chronic conditions have their voices heard and their concerns clearly understood and addressed as the country continues implementation of the new law. To begin our program today, I would like to introduce Bonnie Washington, if you would join us, Senior Vice President with Avalere Health. Bonnie will help us understand some of the ramifications of the Supreme Court's decision. She provides strategic policy advice on a wide range of issues, including Medicare policy development, healthcare reform, and commercial strategy. She has particular expertise related to the Medicare prescription drug benefit, Medicare Advantage, and pharmaceutical and health plan issues. I'm going to ask if you have questions for Bonnie, please hold them. We're really hoping to have time at the end of her presentation to take questions from the audience. So, Bonnie.
Do you want me to stand?
Why don't you?
Okay. Good morning, everyone. Should we do this? Oh, there we go. Okay. Do you want to put it up? Or is there... Is this work? There's also a clicker. Okay. Oh, I'll use the clicker. Perfect. Good morning, everybody. Thank you for having me here today to talk about the Supreme Court ruling and the effect on implementation of the Affordable Care Act. The first slide, I think, is old news to any of you who are not on a deserted island for the last 2 weeks, and that is that the Supreme Court did uphold the individual mandate as a constitutional use of Congress's power to levy taxes. But I think the surprise in the ruling, and what I'll spend the most time talking about, is how the court handled the Medicaid expansion and the Medicaid question that was in the law, which was one that most people in all of the discussion leading up to the Supreme Court ruling, most people sort of blew off the Medicaid question, to use a technical term, as one that the court wasn't was likely not, they were surprised that the court even took it up, and it turns out to be the most interesting and the most controversial thing in terms of moving forward of the ruling. So we'll just dive right into the substance of the ruling. So as a result of the court decision, the court basically said that it's unconstitutional to force states to expand their Medicaid programs up to 133% of the federal poverty level, which is what the ACA required, and that Congress cannot basically coerce the states to do this by requiring that the program funding for the existing program be tied to that choice to expand. So the court basically said you can't hold hostage all of the federal matching funds for the existing Medicaid program contingent on the state's decision to expand, that needs to be a whole new program, and that federal funding for the existing program is not dependent on the state's decision about what they're going to do for the expansion population up to 133% of poverty. That this is a whole new program, it is optional, and federal funding for that piece is obviously contingent on the choice, but not federal funding for the whole program. So this is sort of a major departure from the 40-year history of Medicaid funding, and it raises a lot of interesting policy questions going forward, both in terms of what states are going to do with this new choice, and also lots of more technical questions about what happens to all of the Medicaid provisions that are in the Affordable Care Act that go along with the expansion. Things like the new definition of magi for income, things like the maintenance of effort for states that's in place until 2014. But basically, the biggest question is there's a fly, do you guys see that? The biggest question is that, will states choose to expand coverage, and what does that mean? So basically, the ACA has this new Medicaid expansion up to 133% of the federal poverty level, and all individuals, regardless of their categorical eligibility, would be eligible for Medicaid under that federal poverty level. And then at the same time, the federal tax subsidies for buying insurance in the exchange are for people from 100% of the federal poverty level up to 400% of the federal poverty level on a sliding scale. So what this sets up is a situation where we know that all states are going to have an exchange, whether they're run by the state, the federal government, or a partnership, but now states may or may not choose to expand Medicaid. And so what you do is you have these 11 million people who are people not currently eligible for Medicaid today, below the 100% of the federal poverty level, who would not be eligible either for federal subsidies to buy insurance in the exchange or for Medicaid if the state chooses not to expand. So this 11 million figure is from the Urban Institute's model, and this map shows you how many people are we talking about below 100% of poverty. In terms of who these people are, they are parents or childless adults. Pregnant women and children and disabled people are all eligible for Medicaid through other avenues, and so that really leaves those two groups of people. Most states do not provide coverage for childless adults, so we're talking about most childless adults who are not disabled below 100% of poverty. And the chart on the right-hand side gives you some highlights of where the eligibility levels are set in states for parents. So Arkansas, for example, covers parents up to 17% of the federal poverty level, so the expansion would have built on that 17% up to 133% if they take that option. So we have been asserting, and I'm getting less and less comfortable with the assertion, that most states are going to take the Medicaid expansion because really, why wouldn't they? The federal government is financing 100% of the benefit cost of the expansion for the first 3 years, and that FMAP percentage, as we call it, phases down to 90% by 2020. In 2017, it's 95%, but as you can see from the graph, it is really significantly higher and remains higher than the regular Medicaid matching rate, throughout time. Also, there is a lot of pressure in local communities from groups like yourselves, from providers and others to expand eligibility, because otherwise you're left with this gap in coverage for the lowest income people. But we are hearing more and more from states, and I'll talk a little bit about that later, that they're not going to opt to take the Medicaid expansion. And I think that there are a few reasons for declining the expansion. One is politics. Two is that eventually there is some cost to the state that kicks in. And the third is perhaps overall, that this is not really free to the states, even though it's 100% matching money. There's the cost of implementing it for the state itself, and then there are also the people who are currently eligible for Medicaid but not enrolled, who are going to come and enter the Medicaid system because of the expansion and eligibility and all the publicity that comes with the Affordable Care Act. So I think that while I believe that there are overwhelming economic and practical reasons to expand coverage, we're hearing more and more states who are saying they're not going to do it. Which gets you to this slide. This is the map that the Center for American Progress put out, I think, on Friday, so it's already out of date. And so there are now 7 states, with Texas's announcement, which I think is going to occur today, who have said that they do not expect to expand Medicaid eligibility. So with the addition of Texas, that brings the number of people below 100% of poverty who would be without coverage up to 3.4 million. The dark blue states on this map are those states that have committed to expanding coverage, who have made a public statement, and then the white states are those who haven't said anything one way or the other yet. So this map, I think, will be constantly evolving over the coming weeks and months. And so I think in a precursor to the Texas decision, we included a slide here about what that gap really looks like. So this slide shows you the coverage and what would happen for parents and childless adults in the event that a state chooses not to expand eligibility. So you see this dark blue area is a gap in coverage where people from 0 to 100% of poverty for childless adults, and in Texas from 26% of poverty to 100% of poverty for parents, would not be eligible for either Medicaid or for the federal subsidies for the exchanges. And parents from 0 to 26% of poverty are part of Texas's current Medicaid program and would presumably still be eligible for Medicaid. So I think that eventually, depending on what happens and depending on what states choose, this sort of, I was calling it a donut hole, is not really sustainable, and that as this plays out and as we get more clarity about what all this means for Medicaid, Congress may eventually need to devise some solutions to address this concern. But in the meantime, there is a lot going on and going forward for ACA implementation overall. That when you think about the coverage expansion and the exchanges and the insurance reform, we're looking at really a ton of activity compressed into a very short time frame, which is, as we get more and more into the summer, is really about a year. The open enrollment period for the exchanges begins next October, and so we are looking at a period of unprecedented activity from both HHS and from the states, which Sonia will talk about, to implement all of the things that have to be done between now and then, as well as health plans that are sort of waiting for this guidance and at the same time trying to make business and operational decisions to get ready for programs that they don't know quite what they look like yet and what the rules of the road are. So this is a map of what everybody is going to have to be doing between now and 2014. So we're expecting to see additional guidance from HHS on some very important things like the essential benefits regulation that Merle talked about, additional federal exchange guidance, operational details on many different aspects of exchanges and the insurance reforms, regs on the insurance reforms, and I think new Medicaid guidance coming out of the uncertainty of the Supreme Court decision. And so this map is sort of our take on where states are in exchange implementation and readiness. And again, this map has also changed in the past 24 hours with Texas announcing that they're going to default to the federal fallback by saying they're not going to implement their own exchange. So there are varying levels of activity and readiness of the states, and this will likely continue with most people putting the number of states that opt for the federal exchange somewhere between a third and up to a half of the states in 2014. And then this chart just gives you a snapshot of what it means to each stakeholder group, and we'll hear a lot more about this from the panel that speaks after me. But I think from the health plan perspective, what we're seeing is, like I said, plans, pursuing, getting ready for this new market, and I think today's announcement that WellPoint is going to buy Amerigroup is a great example of my first point, which I didn't know about when we put the slide together, that plans are, despite the uncertainty in Medicaid, are actively pursuing participation in the Medicaid managed care program, because most of the beneficiaries that get eligibility into Medicaid will likely be in managed care, as well as trying to sort out all of the operational and IT and infrastructure uncertainties that come with getting ready for the exchanges in 2014. I think for plans, for life sciences companies, providers, and patients, the Medicaid question really is a big question mark when you think about implications. When you think about the law and the compromises that stakeholders made when the law was being passed, it was really the promise of newly insured individuals in Medicaid or through the exchanges in exchange for lots of taxes and fees and different sorts of payment cuts. And with this uncertainty about the 11 million people eligible for Medicaid, it's a little unclear if all of the stakeholders are going to get the full benefits of the law that they expected, with states saying, no, we're not going to do it. So I think that is a big part of the political dynamic moving forward is, are the people who were promised to get coverage really going to realize the benefits of that coverage, and the stakeholders realize the benefit of that coverage. And so I think just to close out, I think we will definitely see implementation of the Affordable Care Act continue at an increased pace, like a pace probably we've never seen before. And with HHS, the states, and the plans, and really all stakeholder groups focused on addressing the remaining areas of uncertainty to get ready for the open enrollment period in October 2013, with this big question of what the Medicaid ruling means. And then finally, I think even though we have gotten over one of the big hurdles of uncertainty regarding the Affordable Care Act implementation, there are certainly a few more hurdles that we have to get through, the first being the federal and state elections. I think changes in the president, obviously the Senate, and various governorships could make a big difference in implementation of the Affordable Care Act. And then once we get past that, we're looking at a period of great federal activity related to deficit reduction next year, which will undoubtedly have an impact on how the various pieces of the Affordable Care Act go forward. So with that, I will close and turn it back to you.
So if we have questions from the audience, we do have a few minutes, and I would ask that you move to the microphones, the two standing microphones in the middle of the room. Anyone have a question or comment? Would you please, and if you would share your name and from whence you come, it will help.
My name is Susan Campbell with Women Heart, the National Coalition for Women with Heart Disease. And I'm wondering about the decisions that states make not to participate. Is that a governor's decision? Is that a legislator's decision? And how could that change with elections?
I think it depends. I think in some states it's the governor's decision. In other states it is the legislature that has to approve that decision, or the legislature can kind of act independently of the governor to enact legislation kind of requiring the governor to take the Medicaid expansion. So I think it's really, in most states, it's going to be a mixture of both actors.
Good morning. I'm Charlotte Collins from the Asthma and Allergy Foundation of America, and thank you so much for your presentation of the key issues related to the broken promise of the Medicaid expansion. Is there a deadline or an implementation? Is there any sense of imminent decision-making that has to take place among the states in terms of opting in or opting out of the Medicaid expansion?
I have not, there has to be. I mean, if you think about it, we are sort of interpreting the decision as something that the states can make and then rethink. Similar to, if you think about, and I don't know, Sonia, if you agree with this or not, similar to how you think about optional Medicaid eligibility groups today, that you can make a decision one year and then change your mind the next year. But I think for 2014, I would imagine that states are going to have to make that decision by the beginning of 2013 as part of the entire exchange readiness assessment that HHS goes through. And I think that those are the kind of questions that HHS is probably grappling with right now, trying to figure out what sort of guidance is needed, what sort of official process, is it a state plan amendment process or something else, for states to make the declaration officially, and what are the deadlines. But that is all unclear at this point.